what other things are we using to decide what to do with first-line therapy? You know, we have the Charted trial years ago where we added docetaxel. Now we have, you know, multiple androgen receptor signaling inhibitors. We have ARANOTE, we have ARASEMS. How do you guys, aside from genomics, what are you guys using to decide how to treat patients?
Yeah, I mean, looking at high volume versus low volume metastatic disease, I think, you know, with the caveats of conventional imaging versus PSMA PET and helping to determine the number of bone metastases, you know, but using that, many times these patients, if they were diagnosed maybe from urology, PSA is 90, they've gotten a PSMA PET, even if they're, you know, bone mets are 4 or 5 or kind of like teetering on that borderline edge of high volume. I think a lot of times we're having conversations about considering adding chemotherapy to ADT plus an RP in the upfront setting. And maybe that genomic profile might show something that's a little bit more aggressive to consider chemotherapy in that setting as well. So certainly using that classic definition of high versus low volume metastatic disease to help us understand if maybe doublet versus triplet in those situations.
I agree 100%. Low volume, high volume is one way that I approach. And then I also kind of look at how much, if there is visceral involvement and kind of risk for visceral-based disease that might cause, as Dr. Ross mentioned, within that first 3 months, if you have a bad actor, are these the patients that would be somebody that would tank very quickly and not waiting for the first 3 months? That would dictate a more aggressive approach on my end.
Do you as medical oncologists, if we bring them to you and they have a PET, like you said, do you repeat the CT and bone scan just to know where to put them in the charted definition of high and low volume, or do you sort of go off of the...
It's a great question.
That is.
Yeah, what do you guys do?
So a lot of times, I actually will follow the CT and the bone scan, and the reason why is because I'm having a significantly difficult time getting sequential PET PSMAs. Yeah. And unfortunately, this is driven by logistics, but a lot of times when you have a baseline PET PSMA, and then you're trying to get a CT bone scan on top of that, you're gonna get a lot of questions about management immediately right off the bat. Now, on the subsequent, you know, it's kind of difficult to compare apples to pears, you know. So, Dr. Wiele, did you have a...
Yeah, unfortunately, insurance may dictate some of that, but if I have a PSMA PET from the start, I generally prefer to continue with those, stay in the high definition, so to speak, instead of going back to analog. So even though there can be some confounding, if there's maybe a question of progression, on PSMA PET, you know, maybe get a nice CT with contrast to see if there's actually a sclerotic lesion to confirm in that situation. But in general, I'll probably continue on in the PSMA PETs.
So just to ask you a follow-up question, I know you're saying sequential follow-ups with these images. I mean, how often are you following up with the imaging in these metastatic patients? So that just out of curiosity, what is the
routine for if the PSA is responding, I try not to do a sequential large quantity of imaging. However, if the ones that are not responding, I will be very careful to re-image rather rapidly.
Yeah, if the PSA is undetectable, let's say, you drop it out.
I like to, so if someone's initiating treatment, they're on ADT, they're on ABI, or darolutamide, and now we're moving towards chemotherapy, and their PSA is downtrending nicely. Once we've hit that nadir, I'll usually get another scan, so that's now my comparator for a nadir. And then if our PSA is uptrending, that's when I would look to get another scan to confirm if there is any progressive disease. So it's not like I'm getting scans every 3 months on a routine basis, like in kidney cancer, for example. But using the PSA to help guide the frequency of imaging. If you have a more aggressive variant or someone who's a low PSA expressor, even if their PSA has been stable and they're doing well on their RP and ADT, either with or without chemotherapy, then I might consider scans maybe every 6 months or so, just to kind of play it safe and make sure there's not progression without PSA rise. But I would say that's kind of my general practice.
Yeah, I will do, I will use the PSA, but I've seen many cases of transformation where you're not going to pick it up on a PSA, you might not pick it up on a PSMA PET. So even in those cases where it's consistently zero, I might mix in conventional imaging, especially if I have some of those genomic findings that we talked about. So
Just from the urology standpoint, we kind of breezed through it a little bit, but just so I understand, for de novo metastatic disease, and I know what my answer would be, but for you as medical oncologist, is there anybody in your practice who's getting just androgen deprivation therapy? They get sent to you with de novo metastatic disease, or should everybody now be getting something with the androgen deprivation therapy, like you said, AbbVie or Daro or something?
For me, I'm very proactive with the doublets. However, if like a very geriatric oncology patient comes through, it just depends on toxicity. Yeah, correct. I do get quite a few above 85 population, and so for that you have to kind of have conversations about toxicity and differences.
I think that's the exception to where that becomes a real discussion of, does the benefit outweigh those risks?
Yeah.
Yeah, the interesting thing for me, and like what I was awaiting was, when ARANOTE reported, and then we have an FDA approval, we're still waiting for the US studies to fully report. It made me feel a lot better about that. If I was sending to medical oncology a guy who was more frail, octogenarian, I don't have as many, but there are some non-octogenarians, that if you started something and you could reach towards darolutamide, they could likely tolerate it well. If fatigue was the least in that arm, it was also very low in AbbVie, but AbbVie has its own kind of issues, that are like arrhythmias and other things. And so that gave me some comfort that but I agree, there are patients that you could slow roll, particularly if they're lower volume maybe.
yeah, so that's a good point. So how are you guys deciding darolutamide, enzalutamide, abiraterone? Side effect profile?
Side effect profile for me, particularly, again, if we're addressing geriatrics, a lot of times cost now too, because if you're looking at, they may not have supplemental, and if the copay is over $125, $200 a month, a lot of the geriatric oncology patients that are just Medicare coverage, they don't always jump straight into, they have to use the cost plus pharmacy and things of that nature. But outside of that, clinically, I would say that if there is a concern for toxicity risk, I'm more adverse to using enzalutamide, darolutamide, and apalutamide. However, it just depends on the patient profile, and it's the patients, how they're presenting to you. If they have arrhythmias and cardiac-based issues, if they have adrenal-based issues, I probably would avoid using the prednisone. I would avoid using the Zytiga.
I mostly agree. I think, having the conversation with the patient, kind of what are the side effects that they're most concerned about? If it's fatigue, is it the cardiovascular toxicity? Do they have diabetes? Are we on prednisone? That's the majority of the driver of the conversation. I think the ARANOTE data is very exciting, with a little bit better tolerability compared to its counterparts. But ultimately, I think it mostly comes down to side effect profile in your discussion with your patients.
How comfortable and how often do you guys scale up or scale down to the recommended dose? Let's say, Zytiga, 4 pills a day, down to 1 pill a day, or let's say enzalutamide, well, the full doses. Do you? And this is sort of like a question out there. I'm just curious. Do you guys scale down and play with those all the time? Man, you do like 100 minutes.
Yeah.
Calming, no issues, and patient's tolerances, guides.
Yeah.
Yeah, I would say overall, as these guys mentioned, darolutamide has, probably in my experience, the best AE profile. So I use that often. But yeah, if you know what's happening to the patient, you can make a dose adjustment and allow them to tolerate continued medicine.
We have data with low-dose AbbVie in those geriatric patients, and often I'll start them on that. Yeah. And then if they're tolerating it well, talk about increasing it, but maybe not.
And that was my second question was pertaining to that, the older patient population. Are you able to make them?
Many times I'll start lower, just the low dose data it's good.